to this agenda with us. Okay, and the call is being transcribed, so AI is at work. Be careful. We might make it gender transformative. This is purposefully an intimate room so we can really have some key discussions as we gear up for the UN high-level meeting on universal health coverage. So in 2019, Women in Global Health joined together with Women Deliver and the International Women's Health Coalition to form the Alliance for Gender Equality and Universal Health Coverage to send a strong message to the high-level meeting that gender equity and sexual and reproductive health and rights are essential to achieving universal health coverage. We know that universal health coverage cannot leave behind women and girls, or if it addresses some of the areas of health rights and does not address others. I'm pleased to say that the Alliance was an important voice in 2019, and with more than 100 NGO members, we are an important voice today. I have to say we're actually over 200 organizations, so we've been continuing to grow and acknowledge all the members of our Alliance. Member states meet this week at the 76th World Health Assembly shortly after the Universal Health Coverage high-level multi-stakeholder hearing that happened last month in the anticipation of the second Universal Health Coverage high-level meeting in September. This is the right time to review commitments made in 2019 and the status of sexual and reproductive health and rights as an essential part of universal health coverage. When we reflect, since 2019, the health of women and girls in many countries have been put at a grave risk, with essential maternal and reproductive health services being disrupted during COVID-19 pandemic and not treated as essential. It didn't matter where one was getting ready to give birth, but women were being told all around the world to give birth at home and not in health systems. This is completely unacceptable. Despite notable progress in some countries, we have witnessed access to safe abortion and contraceptive services being rolled back with devastating consequences for the lives and bodily autonomy of women and girls. As a civil society alliance, we urge governments to stand firm on the commitments on universal health coverage in 2019, and in particular to honor the promise to safeguard the health and lives of women and girls by reaffirming support for sexual and reproductive health and rights. Today, we have here with us governments and civil society representatives, leaders and experts in the field who will give us different perspectives on this critical subject. We will begin with keynote opening remarks, followed by a keynote speech from our distinguished speaker, and then a panel discussion with questions and interventions from the floor. I would like to note, as I've said before, that this event is being recorded for those who are not able to join this meeting. Once again, thank you all for joining us today, and we look forward to this insightful discussion. With this, I would like to invite Dr. Karin Tegmark Wiesel, the Director General of Public Health Agency in Sweden, to the stage to deliver her opening remarks. Thank you.
Thank you very much. We're very glad to co-host this important meeting. Excellencies and co-hosts, distinguished delegates and partners, thank you for joining this important and timely event in the margins of the 76th World Health Assembly. Important because sexual and reproductive health and rights can never be taken for granted, and timely due to the upcoming high-level meeting on universal health coverage that will take place in New York in September this year. We are here today to learn from each other, to share experiences and progress, but also to speak about the challenges and setbacks in our efforts to progressively realize SRHR in UHC. Unfortunately, we know that comprehensive SRH services are often omitted from national health strategies or benefit packages, with serious consequences to health, life, and well-being of people. We have SRHR needs across the life course. Services and financing schemes must take this into account, recognizing the specific needs and realities of disadvantaged groups such as adolescents, LGBTQI persons, people with disabilities, and elderly. Sweden has for a long time thrived to respect, protect, and fulfill sexual and reproductive health and rights for all. And today, both our national and international SRHR strategies are based on the Guttemacher-Lancet comprehensive definition and essential package of 9 SRHR interventions for all people, everywhere, and across the life course. In Sweden, all maternal health care, including antenatal care, comprehensive abortion care, and contraceptive counseling, is free of charge for all, including asylum seekers and undocumented migrants. We have a dedicated focus on SRHR for adolescents and youth. This includes mandatory comprehensive sexuality education in school and access to youth-responsive SRH services free of charge in dedicated youth clinics. We have experiences and evidence to contribute with from our journey to decrease maternal mortality and morbidity in Sweden. Some 300 years ago, we formalized the midwifery profession and education. In those days, the maternal mortality ratio in Sweden was 900 per 100,000 live births. The introduction of quality midwifery care, later including contraceptive counseling and services, improved medical technology, and the inclusion of SRH services in public insurance schemes has resulted in Sweden having one of the lowest maternal mortality ratios in the world at 4 per 100,000 live births. This tremendous decrease proves more than anything that change is indeed possible. Evidence shows that midwives can meet about 90% of the need for essential sexual, reproductive, maternal, newborn, and adolescent health interventions if they are given the right conditions. The current political declaration on UHC includes SRHR in line with the ICPD Programme of Action and demands mainstreaming of a gender perspective. The political declaration that will come out of this year's high-level meeting must reinforce this commitment with an emphasis on securing implementation efforts. But we see increasing resistance to SRHR globally and a regression throughout the world. The need for increased efforts to achieve and deliver SRHR through UHC has been strongly put forward by various actors, including civil society, throughout the comprehensive multi-stakeholder consultations. To achieve this, we must work together, build on the excellent progress made, identify opportunities to engage in UHC consultations at all levels, as well as be present in national processes defining UHC plans and packages. We must showcase that this is not only the right thing to do, it's also feasible and affordable and the smart thing to do, yielding significant return on investment while upholding human rights. To achieve SRHR, we need functioning health systems and SRHR in UHC. We must see SRHR for the intersectoral agenda, that is, cutting across health, gender, equality, human rights, education, and democracy. I thank you, and I'm looking forward to listen to and learn from the distinguished speakers and partners in today's event. Thank you.
Thank you, Dr. Karen, and especially for really driving home the point that when we invest in SRHR, it is not only the right thing to do, it's the smart thing to do, and especially this intersectorial aspect. Also, what stood out is that you really highlighted the importance of civil society, and this is one of those opportunities where civil society is getting to, together with member states, be able to have this discussion. So really appreciate you highlighting these points. And finally, highlighting the role of midwives and health workers. So I'm really delighted on that note to be able to invite Dr. Pascal Alatoy from the World Health Organization to give keynote remarks and update us on the current global progress. To keep introductions brief, I will just state her brief title, but she has an extensive bio and experience in these issues. She is the director of the Department of Sexual and Reproductive Health, SRHR anti-SRH at the World Health Organization. To you, Pascal. Thank you.
Thank you. You had said this was a safe space and then said we were being live streamed. So I tend to be fairly robust in my intervention. So I think I might, if it is being live streamed, I do need to be. So somebody should kick me if I'm being indiscreet. But yes, I welcome this as a opportunity to really discuss some of the issues. And so that's great. Distinguished ministers, delegates, colleagues, and friends. Bonsoir and bienvenue at Genève and to the WHA 76. I did have a PowerPoint presentation, but I decided with the setup that I will just try and read through it, but I might show you some of the pictures when I come to them. So big meetings like the World Health Assembly are a great opportunity to bring together all of us. It's been a while since we've all been together, and it's lovely to see you all, to meet those who I know already, old friends, and to make new ones. But these meetings are also very expensive. And for that reason, it's important as well to remind ourselves about our responsibility and our accountability to our mandate of health for all. Between 2000 and 2015, the global MMR rates declined by global MMR declined by an average of 2.7% a year. Between 2016 and 2020, the decline was less than 1% or even went down in some places. This means that every 2 minutes in the 2020s, a woman dies from a pregnancy-related cause. Of the 1.9 billion women between the ages of 15 and 49, 270 million cannot access contraception. COVID-related disruptions resulted in approximately 1.4 million unintended pregnancies. 73 million abortions occur each year, half of which are unsafe. Over 1 million sexually transmitted infections are acquired every day. And worldwide, almost 500 million girls and women lack basic access to services and products for managing menstruation with comfort and dignity. Distinguished ministers, delegates, colleagues, and friends, we are all sexual beings, but a healthy and enjoyable sexual life is relational. Conception requires at least 2 people. Sexually transmissible infections occur with another person. The ability to enjoy a healthy sex life at various stages of life may be hampered by pain from a range of disorders, some of which are not recognized, most of which are considered insignificant to have anything done about it. Unfortunately, the relational nature introduces a power dynamic, which also introduces the potential for misuse and abuse of power. So more than any other area of health, sexual and reproductive health is therefore consistently politicized. It is the one area of health where we still, in 2023, have to justify the need for autonomy over our own bodies, where governments, religious bodies, legislature, and prevailing patriarchal systems dictate what we do, with whom, access to care, and even access to products that enable general health and well-being. HRP, the special program, exists as within but separate from WHO in governance because as far back as 50 years ago, several member states objected to the need to safeguard the health of women through the generation of evidence and guidance for contraception. 50 years ago, and it is still the case. So I have the privilege of directing the Department of Sexual and Reproductive Health and Research, which includes the UN co-sponsored Special Program for Research and Training, HRP, and the WHO Department of Sexual and Reproductive Health. This is co-located in the WHO Division of Universal Health Coverage across the life course, and managed to the science division, which means that we have two bosses. This has been a significant advantage, contributing to an environment in which from WHO's perspective, we're able to facilitate the integration of sexual and reproductive health into universal health coverage. It's also a significant advantage that the special program on primary health care is part of that division. In principle, therefore, this process has occurred through one of the units within SRH that focuses specifically on the integration of SRHR in health systems and works most closely with the other departments in the division. So we have Dr. Lale Esai here and Dr. Viloshni Govenda. Viloshni is somewhere. So if you have any questions, ask them and not me. And they're both here and available to support technical details during the discussion. And a lot of the work is based on the development of health benefit packages that include key sexual and reproductive health services as a key step towards towards universal health coverage. Now, the role of HRP, the department, is ensuring that sexual and reproductive health is incorporated within UHC and is underpinned by principles of human rights, gender equality, and a people-centered approach and equity. So a lot of the work and the products actually are based on this principle, specifically led by Lale and Viloshni. And last year, I believe it was last year, that we produced a number of online resources that help support member states in integrating SRHR into UHC, and there's an interactive website as well that allows for case studies, for countries to contribute case studies about how this happens. This was one of the pretty slides that you won't see, but I'll send the link. Going back, therefore, it's a useful time now, given the high-level meeting in UHC, to kind of look at what we committed to in 2019. The commitments were around ensuring political leadership beyond health, ensuring that we would leave no one behind, to ensure legislation and regulation, upholding quality of care, investing more and investing better, and doing more together. And these come together as well in WHO's 13th General Program of Work with the strategy period 2019 to 2025. Since then, we have lived through a pandemic that has significantly tested the robustness of these plans. The measure of our humanity is how we engage with issues of equity during crisis, and we all know that we did not do well. We certainly did not do well by women, and while we're still in the process of assessing how we performed, what we can say is that SRHR is insufficiently funded at both global and national levels. There still exist restrictive laws and policies, gender norms, stereotypes, and inequalities and health systems constraints, which include insufficient integration of comprehensive sexual and reproductive health services in health benefit packages, and primary health care is still a challenge in many countries. And while a lot of the arguments are about being able to prioritize, we know that women and families are impoverished through catastrophic spending to access health care. But for the first time, military expenditure surpassed $2 trillion. And I just picked up this figure yesterday from the Stockholm Peace Research Institute. So it's not, the funding, the resources are there. And so there is a real case that we can make and we should be making, just using these sorts of figures to really try and push for accountability for why this area is not properly funded. Most countries we know now from a review of from a review of UHC commitments, we know that most countries have strong national commitments and targets for UHC, so most countries have made those commitments. However, country commitments and reporting on UHC is not always necessarily linked to a UHC strategy. Government plans and reporting on UHC often focus on specific diseases or services in a very fragmented manner. There's poor participation of non-state actors in UHC planning and progress reviews or implementation. So there are different things happening at the grassroots level in various countries, but we don't have a coherent story. Equity is strongly acknowledged in government's UHC initiatives, but very poorly operationalized. So getting back, what does it mean to try to get back on track, if that is what we're looking at and part of what we want to address here as part of the discussion? We know that primary healthcare approach allows for a lot of the things that we value, specifically for sexual and reproductive health. Primary healthcare provides that as a framework because it's participatory, because it's multisectoral. It addresses the social determinants, including equity. The services are close to communities, and it has a human rights approach. It ensures that sexual and reproductive health services are available and are affordable. And one of the I guess, innovations from WHO at the moment is that there is a clear UHC compendium that I know Lale and Velosh worked on as well, that provides that support for countries to be able to put together the packages to match those up with their level of financing and to help in the priority setting exercises. There's a whole lot of stuff here that I won't go into. It will be fun on a PowerPoint, but I'm not going to talk through them. But I do want to stress that at the very least, from the perspective of our department, Sexual and Reproductive Health and the HRP program, one of our priorities is ensuring that we are engaging with partners. This is not something we can do on our own. And if we even take the kind of a very research intervention-based focus, we published a study about 3 weeks ago in the New England Journal of Medicine that looked at bundling interventions. So we have all of these guidelines that give us that are based on the research that we've done that show that a particular intervention is best practice and with all of the evidence. But what this study did was actually bundle these together so that it's not individual. We're not testing individual interventions. We put them together as a package. And within the study was still ongoing, but very early it showed that they were able to achieve a 60% reduction in postpartum hemorrhage just by ensuring that the packages, the interventions were bundled rather than focused on single ways. So it's very clear that if we come together and we do this properly, we can certainly accelerate the efforts that we have. And this means, and I've got this busy picture here, that within the context of who we engage with very specifically for sexual and reproductive health and rights, we have access to the 3 levels of WHO. So it's the regional WHO regional offices and country offices. We have access to our UN co-sponsors. So it's UNFPA, UNDP, the World Bank, WHO, and UNICEF. We have the opportunity to work smarter and work better with the private sector because so many of our populations are not going to the national health services. They're using private sector. How do we make sure that we have some coherence in working together? We have a whole range of other multilaterals that we can work with, including the Human Rights Commission, UNAIDS, UN Women, and so on. We can influence our donor communities, and it's one of the things that we're trying to do very systematically, that we don't follow the money follows the priorities. And we get those, we identify those priorities by new ways of doing research agenda setting, by engaging much more strongly with communities, with civil society, and so on. We have access to academia because of the research focus, and we have access to policymakers, and we're increasing our engagement with parliamentarians. So there are lots of people that we can work with. We need to think about how to strengthen those alliances and work better. And if for nothing else, we know that there are lots of people that are against the sexual and reproductive health agenda. I have had my fingers, my toes, and my eyes crossed all day during the World Health Assembly as we've gone through the review on the progress report on the global strategy for women's, children's, and adolescents' health. As some countries are very boldly talking about sexual and reproductive health. And I'm thinking, please, nobody complain about this, otherwise we're going to open up a whole debate. And that is something that we had a recent experience at the governing body of HRP, where one of the member states probably hadn't realized that it wasn't the best place for him to raise objections, but he did, as member states are supposed to. But it did make for a very awkward conversation in not wanting us to use language that was not UN accepted language. So we know that we're not working in a particularly friendly environment. So if we don't find ways of joining efforts to really push the agenda forward, we're not going to get very far. I wanted to end with again, another lovely image. I just love this photograph, the Time Person of the Year, with the story of Salome Kawa from Liberia, who was in 2014 was the champion health worker who survived Ebola in spite of it pretty much decimating all her family and community, 2014. And in 2019, having survived an Ebola outbreak, then died from complications of childbirth. And that should not happen. Thank you.
And thank you, Dr. Pascal. I'm not going to try to summarize your incredibly grounding keynote. You provided us numbers that you have not only left as numbers, but humanized for us. These lives lost, lives that could be saved, lives of many women and girls. It's not just numbers, but these are human lives that we're losing out on. But you also really echoed the importance of partnership, and especially in this room where we have civil society attending in high numbers, as well as the member states, researchers, and hopefully donors and other entities. So it's critical that everyone has a role, and it's critical we use evidence to drive and make the case, and all the different strategies. So again, I will not summarize your keynote there. I'm sure many of us want to know where we can find this latest data. So we will turn to you and the colleagues, those that want to learn more about it, but it's great to see this work coming out of your department. So thank you very much. So on that note, we will be turning to the panelist section. I'm going to actually kindly ask our two keynotes so we can bring the panelists closer. If you can go to the floor again, a round of applause. Thank you. We're playing a bit of musical chairs here, so thank you. So now to our high-level panel. I will begin with just doing a round of introductions, and then we're gonna go in from that point. So today we are joined by distinguished guests, Her Excellency Kumbize Kandodo Chimponda. I will, of course, say please correct my pronunciation for sure. Minister of Health, Republic of Malawi. We are also joined by Her Excellency Dr. Carla Vizzotti, Minister of Health of Argentina, also correct my pronunciation, and Ms. Lydia Saloku Sugranga, President of Pathfinder International Africa, and I'm sure you'll correct my pronunciation. I really should not be able to make so many mispronunciations in French since I lived a few years there. But also joined by Dr. Deepika Saluja, Chair and Co-founder of Women in Global Health India. So again, esteemed panelists, thank you for joining us today. I'm going to first ask Honorable Minister from Malawi to particularly address us first with your intervention. Thank you.
Thank you so much, our coordinator this evening. All protocols observed to my fellow panelists and our dear keynote speakers. Thank you so much for the information and for sharing. You've shared very important information. And all colleagues, good afternoon. I'm so honored to be here. Like she said, my name is Kumbiza Kandodo Chiponda. I'm a pharmacist. I'm a pharmacist by profession, but now I also serve in the capacity of being Minister of Health for the Republic of Malawi. It is an honor to be here, especially on this very, very important topic of sexual and reproductive health and rights. A very important topic for us as leaders, political leaders, very important economically, because these issues, to me, it's more than health. It's not a disease, so it's more than health. It has economic implications, it has got the development implications, it has the political implications as well. So it is a very, very important topic for all of us, for all the countries across board, regardless of race, age, or whatever you can say. And so as Malawi, the keynote speakers, they talked a number of issues. And most of those issues, we can, relate to them, where we're coming from, where I'm coming from in Malawi, the challenges which are there. She talked about a number of issues that people, they still have to walk long distances just to have access to health services, availability of the services themselves, family planning services, but also you bring in cultural issues. You cannot overlook cultural issues and also religious issues as well, because they play a very, very important part where we are coming from, not just Malawi, but in some parts of the world. You cannot bypass religious issues as well. They've got a great implication on how you address issues related to sexual and reproductive health and rights. And of course, the implication on our children. All of us, we are complaining that number of our young girls getting pregnant, teen pregnancies, and the Africa as a continent, but also as Malawi, almost 50%, it's the youth. You've got a very, very youthful population, which is a plus, but also it can be a minus. It depends on how you handle them. And so this youthful population, you need to have strategies on how do we assist them, especially in the issues about sexual and reproductive health and rights. In the other issues, programs, HIV, whatever, we are doing very, very well. But like the example Dr. Pascal said, it would be unfortunate that you have saved this child from HIV, from everything else. You have invested a lot in vaccination and everything else, just to lose them because they had the backdoor abortion. It's things like those, but that is the reality which is on the ground. So as government, in Malawi, all health services that are free, including sexual and reproductive health services and rights. They are free. You don't have to pay for anything. And they are provided starting from the community level at primary level healthcare services. That's how we do it. Having recognized that we do not have enough facilities, hospitals to provide health services in our communities. So we have said, how do we strengthen what we have, the little which is there? So we have what we call village clinics. right in the village, just trying to bring the services to the people. Not all the services, but some of the services and family planning issues, they are part of those services, just to make sure that the one who is living with the people, they should have these services, but also the information. And so in our communities, we start at a village, we have the village clinic. After village clinic, then you have a step ahead, which is a health post. You have like a nurse or a midwife there, maybe a clinician. From there, then you have a health center. From there, then you have a district hospital, and then we go to the secondary level and the tertiary level. That's how we provide our health services. Where you don't have a government facility, we have working agreements with faith-based hospitals or health facilities, which as government, we pay for the services so that people can go and get the services for free. Not everything, but issues to do with maternal and issues to do with the under 5, and of course the sexual and reproductive health services that are also provided. So basically the main things which we provide, the family planning things, whatever, pills, injections, loops, everything is there. And of course also including HIV preventive like PrEP, but also now the morning after pills, things like those we provide for them. But also the most important thing is that as the Minister of Health, we also work very closely with education, because I think information is power. It's more than the pill, it's more than anything. So I think we need to equip our girls, our boys with information. That will make them more powerful, and that is going to empower them. So we work closely with the Ministry of Education, but also with the Ministry of Gender and Community Development to make sure that we get to the target group, the women, the adolescent, and the youth with the right information regarding sexual and reproductive health, and of course their rights as well. Like I said, some of these topics, they're sensitive, but you need to have an approach. Like I said, you need to know the community, the constituency which you are looking at, which you are working with. Then you can know the right approach to deal with the situation. The main challenges, I think, is that we have less sponsors or maybe less partners, because we know with COVID, most of our partners, they also have been financial problems. So some of them, they have reduced the support which they were giving towards this, even towards family planning. So, but the Malawi government, we made a decision. And for the first time, I think we increased our budget towards family planning by over 100%, because we said, no, we have to, we just have to step up. So we less partners or less sponsorship into the subject itself. I think it's a huge problem, because all these things you have to buy as government, and nothing comes for free. So it needs a lot of partners to be interested. You can imagine COVID, because everybody else was interested. Within a year, you found solutions. You had vaccinations left, right, and center. Because everybody, they were like, hey, it might be. But things like this, we are talking of backdoor abortions. Some of these, they're not interested, because some of their people, they don't face these things. So, they're not interested to find some of the activities which we need to engage our youth, because this is not an event, it is a process. You want to take that girl from early childhood in nursery, take them up to primary, secondary level. You have to give them information according to the age which they are. So it's not an event that okay, I'll sponsor one day and then it ends there. No, it doesn't. You have to keep going to tertiary. So it is that costly. So I think for now, let me just stop there. I can keep going and going and going. Thank you.
Thank you, Minister. Again, so much to take away. I mean, you outlined it from beginning that working on these issues and investing in the sexual reproductive health and rights is a health, economic, development, and political issue. And the many strategies you shared about really getting family planning services into communities as much as possible, and also really just acknowledging the fact that if we save a woman's life and then lose them to a backdoor unsafe abortion, I mean, we've lost the game altogether. So you really drove that home message, and acknowledging that in these challenging times, you were able to double the budget on this. So again, congratulations. On that note, I turn to the Honorable Minister of Argentina for your intervention on the issue of universal health coverage. Thank you. You can pass the mic.
Thank you very much. Good evening to everybody. It's a pleasure for me to be here on behalf of my country as Minister of Health, woman Minister of Health in a decision position, and as a woman also. So congratulations for organizing this event, and we are very proud of also to co-sponsor the event. I think it's extremely important. In Argentina, we have experience in realizing sexual and reproductive health rights in universal health care. We strongly believe that ensuring the effective enjoyment of sexual and reproductive rights for all people is a priority. It's a national priority and should be a regional priority, and also in the global level. We can share some achievements and challenge from Argentina. Our country has incorporated the society's claims and fights for equity, women's fight. They came from a long time, and our government, our president, could hear and committed to really incorporate these rights and send some laws and framework to the Congress, and it was successful. Our society claims and fight for equity, non-discrimination, and eradication of gender-based violence, taking these social processes in line with international regulatory frameworks and enacting national legislation which is groundbreaking and acknowledging the rights of women and LGBTQI+ people. Transversal gender policies. In Argentina, we have 3 transversal cabinets. One is regarding gender, one is regarding climate change, and the other one is regarding mental health. So in a way, the 3 of them are related with health. The 3 policies has an impact in health, and the president decided to have transversal national cabinet. So all the cabinet, the ministers from the national cabinet meets regularly to talk about these issues. This government decided to establish the Ministry of Women, Gender and Diversity in 2019, and the prioritization of gender policies and claims of women, feminists, and LGBTQI+ community movements in the public agenda. And the ministry is focusing on the cultural and structural dimensions that produce inequities among genders and gender-based violence. In the Ministry of Health also, there is the first time that there is a direction regarding gender and diversity, and we are working with the 24 provinces from Argentina in this aspect from the health implementation point of view. We also have a national law for comprehensive protection to prevent, sanction, and eradicate gender-based violence in the interpersonal environments. Since 2011, there is a very strong law that is being implemented since then. And we are very proud of our legislation. We have really strong laws that have a very wide perspective regarding sexual and reproductive rights. And for example, since 2002, Argentina has a sexual and reproductive rights law, which is in charge of delivery contraceptives and to train in schools and in the health centers regarding sexual and reproductive rights. We have a comprehensive sexual education law since 2006. Argentina has the equal marriage law since 2010 gender identity law since 2012, transgender job quota law in 2020, and in 2020 also we reached the law on voluntary interruption of pregnancy. We had a presidential decree that acknowledged the non-binary identities in the ID cards and passports since 2021, and also a law in comprehensive health care during pregnancy and early childhood. It's the 1,000 days plan that went together with the abortion law. If a woman decided to interrupt the pregnancy, she has the right, and if she decided to go on with the pregnancy, there are a lot of comprehensive actions from the state that goes in that way. Regarding the program of sexual and reproductive health, we work in primary care, in the primary level. This is extremely important regarding prevention of pregnancy, contraceptive methods, and also the access of abortion with the 24 provinces. Our program guarantees free access of contraceptive methods and other sexual reproductive health supply to the entire population. As part of a strategy, the program has been purchasing the contraceptive methods and other supply through the Remediar program. Remediar program is a national program from the national level to the primary care centers that deliver essential essential treatments. And we have a special strategy regarding reproductive and sexual rights that provides anti-conceptives, but since 2022, it also provides misoprostol, and this year we are going to include mifepristona. And another point that is very important is that misoprostol is produced in Argentina. It's a national production because we work strategically to be sure of the access and the production. And one province in a public laboratory is three provinces in public laboratories. They are producing misoprostol, and the distribution for free in the healthcare centers is a national production. That it's also a strategic decision, and it's very important, and we are very proud of that. And also we are working. Okay. Exactly, in the primary centers, yeah. And also another thing that just finishing the sexual and reproductive rights are very, very close, and they go together with the universal health coverage because with all these policies in Argentina, there was a reduction of 40% of women died for abortion since the law has been sanctioned. You know, in 2 years we had 40% of decrease of women death regarding abortion. So there's no doubt that sexual and reproductive rights should be included and have in the universal health care. And this strategy has a positive impact, decreasing mortality and making women to be better access to these rights with empathy, with a human rights vision. And we need to keep training healthcare workers, people who have any doubt about that. It's a huge work, but it has a huge impact also, not only in the mortality, but also in the well-being of women, and we should keep fighting for that. Thank you.
And Minister, a lot of highlights from you, but what really stood out, I mean, there were so many things to highlight there, but you really drove home how you're linking the rights approach, the human rights approach to everything you're doing in Argentina at this point in time, and putting it into law. and putting in laws that are also looking at this from a very intersectionality point of view, and making the case of why this investment is actually a human rights issue and needed and not to be disrupted. So I think many that are keen to learn about Argentina's approach, we've learned a lot today too. So I actually next we'll turn to Lydia, our partner from Pathfinder Africa. How have you engaged in universal health coverage processes, and what are some successes that Pathfinder would like to share today? Thank you.
Thank you, distinguished ministers, key notes person, and colleague. I'm really happy to be here to share what we are doing in Burkina as a civil society organization. I listening very carefully what ministers are saying. Sometimes in sitting in the other spot, you have another, how to say, another way of looking at this. As you know, Pathfinder is an international organization with a focus on reproductive health. And our most mission is really how we can work to reach the most vulnerable and deserved population in the different countries we are. And we think this includes giving care to women, to children, but also health education and empowering community, because sometimes we are talking about everything in terms of helping the system, but I think also the community have a part to play in this big role to access to universal coverage. I'm sure I was appointed as president of Africa for Pathfinder, but today I want really to talk about a country. Why I'm choosing to talk about Burkina is because I think in 2018, Burkina was awarded by the ICPF of the work they are doing on reproductive health. And as you know, the country went to different situations, political situation, but also security situation. And this also have an impact in terms of how we can achieve universal health coverage. And our role as civil society is really to be, to pay attention of what the government is doing and how we can keep really the progress we did since this moment, to be sure, because still we have this situation where are still women behind this situation. Is about life, is about women, is about what we need to build and serve our population. And today I want to talk about two things we did with to ensure the health of women, especially reproductive health, is included on what the government want to do. The first is around advocacy. It's our role really to see, based on the engagement the government is taking when we are in different, how to say, space and meetings and conference, to see how we can follow up. And we settle a watchdog organization to look at this. The second things in terms of advocacy, we are doing a lot also, how the government can put money in terms of reproductive health. As you know, the Burkina went for free access for family planning based on the advocacy the international NGO, but CBOs did in 2018. But saying free, it means also someone is paying, and it's not sustainable to go with it. And our role also is to reflect and and decide with the government what kind of strategy we can put in place to really bring domestic funding. And this is really important. In a country like Burkina, where most of the funding is going to preserve the territory, is difficult sometimes to bring, I will say, to bring economic people to fund reproductive health and so on. And the idea is really how we can work with them to find new strategy. Another way, for example, how we can put taxes on drink, beers, and so on. It's not easy because the finance department also are looking to it to help on the security side. It's not easy, but we are trying to do our best to recall the government and remind them that we need really to keep going, keep giving space for women, keep really be focused on SRH. And this is for us our role. In the others' role also we have is really how we can help in terms of improving the quality of services. And we are working mostly with public health facilities in terms of training, in terms of ensuring equipment and so on are there. This is one of our role. But based on our real situation, we think also in terms of workforce, we need to think in another way. And last week, we launched the recruitment of 15,000 community health workers. And the focus will be on the IDPs, because as you know, with the situation, there is a lot of population who are moving, and the mobile facilities and so on is difficult due to the security system. Now, what the government pushing by the civil society is to identify in the community people who can be trained to be community health. They can move with the community when things happen. They can help also the women and also the children in terms of access of services. And one of our work also is really how we can intensify the delegation, the task shifting, because it's important to see how we can do it, and also the auto-injection, everything around this. And I think for me, based on what we did, my thinking is it's good globally to have, politics, to have, strategy, but it's also good to adapt it based on the context. Sometimes it's difficult just to apply what we decide at the global level. I think we need to be more, strategic, to be more also how we can be led by local solution. And when we are looking at local level, we can find also solution, how people are dealing with the situation, and how focus on this, we can make it more, more formal, more strategic for over all the country. And one of the things I want to add before stopping at this is, for me, based on the situation, what I learned is really when we are talking about health, we need also to talk about empowering women. Because when you want to go to universal coverage, it will be really important for women to be economically powered, but also to be able to say, I want to go to and to have these services. And this is a lot of work to do with the government, but also with the civil society. Thank you so much.
Thank you so much, Lydia. And there is so much to pick up there. But what really the strong message that came out is that local solutions matter. Civil society has a role for advocacy, but also of being responsive and working in partnership with government, and thinking about how to mobilize the resources and in creative ways, and making sure that those resources go back into really supporting the needs of women and girls and the population's health need on family planning. So again, thanks for that deep dive on Burkina Faso. I'd like to turn next to you, Deepika. Please, your reflections on this agenda, and we're going to pass the mic. Thanks.
Thanks a lot, Rupa. I think it's no less than a pleasure to be sitting with such esteemed panelists, and I can't thank Women in Global Health enough for that opportunity. I just want to start with sharing a recent incident that happened in India. A 30-year-old man killed his 12-year-old sister after finding blood on her dress, mistaking menstrual blood for evidence of sexual relationship in Maharashtra. So Maharashtra is the state, Mumbai is the capital of Maharashtra, just to give you a bit of reference. So she had her first menstrual cycle, and she was living with her brother and sister-in-law. Her parents were are living in village. The man, fearing that his sister is actually indulging in sexual relationship without actually engaging in any conversation, he got angry, he started kicking, punching, burnt her with tongs. I won't go into the details, but the message that I'm trying to communicate here is that we're talking about a huge proportion of population who is ignorant like that, lack of respect, lack of understanding and knowledge about women's bodies, which is coupled with deeply rooted patriarchal misogynistic expectations in the minds of entitled men that lead to these horrifying incidents of violence perpetrated to women. So when we talk about sexual and reproductive health rights at the ground level, what is exactly happening, and a lot of panelists have already pointed out that the solutions or the policies that we talk about at the global level, we need to go to the ground and understand the contextual realities and really understand what strategize accordingly, what are exactly the needs of the population. In this case, I mean, having a non-virgin married woman in the house, according to the brother, could mean inviting shame and dishonor for the family and the position. And that's why he went ahead with this kind of violence in a way to show it to the society that this is how you treat or punish women who kind of cross the lines of patriarchal norms and boundaries. So, I mean, women are treated everything but equal and respectful. And without having open conversations, and when we say open conversations, we're not talking about open conversations just in an elite group like ours, but actually down to the community level, where these patriarchal norms and regressive ways of functioning and expectations, gendered expectations, are so deeply ingrained in the behavior and expectations and minds of these men and society overall. And making sex education compulsory and comprehensive is no longer a choice. We're not talking about whether we should do it or not. It needs to be a part of the curriculum to eradicate ignorance and break down all the shame and stigma that comes with the regressive ways of existence for women. And lastly, that we cannot achieve all of this without the engagement of men, without the engagement of boys, without having them as supporters, as allies, as engaging very actively in standing up and supporting for the rights of women and girls. So yeah, with that, I'll stop.
Deepika, you opened with a story that, moves and shocks all of us. And again, I go back, we heard about the millions and millions of lives that are lost, the lives lost every 2 minutes. And these are women, these are people in our communities. We must take action. I'm going to change the program a bit, and I hope our ministers would be okay with this given the time. So we're going to go to a rapid fire question, and I will kindly ask to really stick, as we say, what would be your tweetable message, or what would be your, a take-home strategy. Each one of you, each of the panelists in your own ways, our ministers, our civil society, are using strategies in these very challenging times in your own cultural context. What is one strategy to really advance this agenda when we know that challenges are coming from all aspects? So I'm going to first turn to the Minister of Malawi to give what is one strategy that we can copy and paste, we can take from your context and potentially share and use in other environments that you'd like to share.
One strategy which I think would work for all of us is in the spirit of leaving no one behind, should also be, everybody should be involved. So you don't want to leave anyone behind, but everybody should be involved. Collective responsibility. Thank you.
Thank you. Passing it to Minister of Argentina, please.
I agree with my colleague from Malawi, but also I think that the strongest force in Argentina was the civil society, the feminism, the movements in the streets, the society empowering for their rights. This is very powerful. Our women in Argentina, we are very powerful, and that started long time ago and finished in the Congress with this abortion law, and we keep fighting on that, because it's not that we have a law and everything works. We have conservative groups that tries to stop the law through legal presentations. We have more than 35, and the justice was in favor of the law. It's a very strong law, and also in the healthcare center they try to interrupt the access to the right to the abortion in sites also. So this is not end in Argentina. We have to fight for our rights every day, and we have to know that political decisions are also important. They can change in any minute. We saw in US this situation, and we are very worried about the step behind. And we also ask Tupajo to introduce for the first time in the agenda of the executive committee the sexual and reproductive rights, which were not clearly involved. So it's local, everybody involved, the social society, the international organizations in our region, I think that the responsibility that we have, we got it from women, powerful women that came before, and we have the responsibility to leave these rights to the girls that are coming, and it's also with men. I'm sure that everybody should be involved, and there are a lot of men that are with us. Thank you.
Thank you. Many things to say, but I will stick on investing on women, because sometimes we have projects, and I think project will not bring us anywhere, and we need really to invest and to do we call it financial case, to see how much it costs to go from one stage to another stage. But at the same time, I want to do a call, because sometimes it's really important to get donors, to get partners working together. But I think if really we want to help countries, we need also to create alignment, because sometimes people come with, their priorities, and sometimes it's difficult, it's disturbed sometimes the government to do or to commit or to implement their commitment. This is my last words. Thank you.
Okay, I'll borrow my points from how WGH has been able to kind of garner the attention and commitment within the gender equality space. So one is mobilize public support, develop clear messages, and garner commitments from the policymakers and actually hold them accountable. So this is, one way which I feel that needs to be taken very, very actively when we talk about advocacy to be able to see any impact. And just one more point that I would, and I'm borrowing this from another speaker I heard, that whenever we talk about gender equality, sexual reproductive health rights, we keep on advocating, we attend so many events, we talk about it, we push the agenda. But a very important thing to reflect in our own lives is that how are we living that? When I'm advocating for gender equality, when I'm advocating for women's agency, when I'm advocating for SRHR, how am I at an individual level fulfilling that responsibility? Thank you.
One word. I think that the main thing is to have women and diversities in decision positions. That's important to keep going.
So we're going to now open up to the floor. We have two interventions to kick us off. And so I would like to, I'm looking for where Ms. Claudia Zymes from the International Federation of Medical Student Associations, if we can pass the mic to her, or I will walk. Just from the floor, please.
So thank you. I'm Claudia from the International Federation of Medical Students Associations. So I was about to share our positive examples on SRHR from our perspective. So the very first point to achieve quality service is to understand the needs and assess them in the first place. So for us, the very first step was to assess the shortcomings of medical education, because you cannot achieve UHC without having the workforce educated on SRHR. And this is why we surveyed our medical students from 130 countries on how is their experience on including SRHR in their curriculum. So on another note, the power of IFMSA lies with our national member organizations, because those are the people that reach out to communities. And UHC also means access to health information, and this is why our national member organizations work on the ground and deliver meaningful and impactful activities. And we have a couple of examples on menstrual health campaigns in Gambia, Kenya, Lebanon, and Nigeria, but also SRHR awareness campaigns among adolescents especially, conducted in Indonesia, Moldova, Portugal, Poland, and Romania. And some other countries, such as youth from Thailand, Brazil, and Bangladesh, they focused a lot on trans community and their access to health information, so they also work on that. Because health literacy, especially in the context of SRHR, means understanding your own health needs, and this is the very crucial step to achieve UHC.
Next, we have an intervention from Ms. Linda Zymes, a researcher in Finland and also part of the Women in Global Health Finland chapter. So yes, the floor is yours.
Okay, I'm a doctoral researcher that looks at how the opposition to SRHR targets international forums. In particular, I have looked into the rolling back of language on SRHR in UN documents, as well as opposition strategies and influencing at the level of EU institutions. I therefore have a couple of quick comments and suggestions from our panel. We cannot have health without SRHR. However, as has been said, SRHR has been more and more contested, and also forums are subject to influencing from external actors who are well organised and financed. We have an entanglement of opposition NGOs and regional bodies who create alternative conventions and submit alternative resolutions, which means that language originating from offshore countries can end up in documents in other regions, signalling foreign interference in health policies. This therefore creates significant challenges for health policy making more broadly, a subject which, amidst the politicisation of SRHR, is often lost. My first question, therefore, is what opportunities are there to bring countries together successfully to protect SRHR as a right to health in this environment, and how can we advance our advocacy together? Lastly, we are seeing language on SRHR being reframed as harming women and human rights language being co-opted and manipulated into language which, in practice, excludes access to critical SRH services. Through reframing strategies, opposition actors can spin in anti-SRHR language to come out sounding more reasonable to diplomats and representatives who are not aware of their tactics and language, so we need to monitor all discussions where this takes place. Dr. Pascale Alotte presented the statistics on egregious harm where these restrictions are in place, so I won't repeat them. But these health consequences from restrictions are totally absent from the emotional opposition framing, for example, that abortion is murder. Of course, nothing about the preventable deaths of women and LGBTQI people who are denied access to simple and safe procedures, which is their right. Because, as Dr. Deepika Saluja said, a huge proportion of the population does not understand these matters. My final question, therefore, is how do we strengthen our evidence-based messaging to counter the evidence-free messaging we see from opposition actors, and how do we make the voting public understand this too? Thank you very much.
Thank you, Dr. Linda. So turning to the floor, I saw a few hands go up. I want to make sure I look around. Okay, great. Two next to each other. Great. Would you just? I can go up to them. No worries. It's a small room here. If you could please say your name as well as introduce your organization.
Thank you so much for a great discussion. My name is Marine Zagam, and I am an OBGYN. I am an associate professor at Lund University in Sweden, and I work at the program in global surgery and social change, Harvard Medical School. I have two questions. The first question is directed to you, Dr. Karin. We are very proud in Sweden of the strong maternal healthcare services and reproductive health services we provide, but during the pandemic, we were one of the countries, the developed countries, that were very late to recognize pregnant women as a risk group. Additionally, we have a healthcare crisis where our midwives, which you talked about, are leaving the workforce and getting burnt out at all major university hospitals. So I would like to hear your opinion about the situation in Sweden as a model, as you're saying, in the sexual and reproductive health globally, as a country where most countries look to. My second question is actually to the other panelists, and that is related to the alarming rise of surgical cesarean sections around the world. Dr. Pascal, 38 million operations by 2030. Every third baby in the world is projected to be born by cesarean section. 88% of those are in low and middle income countries. You talked about catastrophic expenditure to our women. Think about the cost of a cesarean section in India, in Argentina. That family is, majority of them are not medically indicated. What can we do to curb the rise? We need more action from agencies like the WHO to give, they have given recommendations. I've read the recommendations many times. I'm sorry. And what I actually do have a small question for you too, Rupa. A very small question, 30 seconds. The United States of America, abortion care, as the leader of the democratic world, why are we doing more to help abortion care with the policies in place now? Thank you.
Thank you for your questions. I'll just clarify, I do not represent the United States, but I do represent an organization that is hosting today's event where we are exactly calling to protect the sexual reproductive health rights of all people, especially girls and women, and where we need to make sure the safe access to abortion is there. So personally, I have my organization's position, not the United States government. I will ask for the second question and see if there's any other questions, because we're going to then turn it to the panelists for a rapid fire of answering questions. I know the woman right next door also had a question. If you could please state your name and where you're from, and hopefully keep the question very brief. Thank you.
Thank you very much. I don't have a question, but I want to comment and first thank the organizers of this session for organizing such a very important session. Also thank the panelists for sharing their interventions and the work that they do in their countries. I'd also want to address myself to my minister from Malawi. I am from the SADC Secretariat. Sorry, I haven't introduced myself. My name is Dudu Simelane. I'm the director responsible for social and human development, and that includes health. Just like to confirm what the minister has said, Minister of Malawi, and to also say that as a SADC Secretariat, or as SADC, we have a SRHR strategy and scorecard, and the minister is indeed a champion, as you see her speak here. She does a lot of work. What she's saying is what she does. And in the region, last year or the year before, she was chairing our ministerial committee on health, and she launched our scorecard. So all I'm saying is that this is a good initiative, and we encourage the countries to continue. But I also want to share some information that as we speak about UHC, as SADC, we are having a meeting next week. We're trying to, and it is themed situating UHC into, or situating SRHR, into UHC for sustainable financing. And that's something that we are working towards because of the September high-level meeting, and we want to really position ourselves in terms of UHC and SRHR. But secondly, I also want to say that we have the scorecard, and in this meeting next week, we will be doing or presenting our draft report on the second milestone report on the scorecard. I want to acknowledge Sweden, who supports part of that work, and the United Nations. Thank you.
There is one last request. I'm going to say very brief, introduce yourself, and 30 seconds.
Thank you, and thank you so much for putting together this fantastic panel and discussion. I'm Archana Patkar from UNAIDS, and I just wanted to really thank you and celebrate the accent on local context, partnerships, collaboration, you know, and the gamut of issues that we're looking at. But let's go back to all of you raised this. This is about disrupting patriarchy and destroying power. And we wouldn't be here today, you know, having this discussion if it was easy. We are looking at this decades after CEDAW, and I think it's going to require us to declare this an international and global emergency that has been in place way before COVID. So perhaps we need a strategy and action to really move forward. Thank you.
Thank you. So we are nearly at the time of event. If anyone does need to leave, I understand, but we are going to give our panelists the chance to do very brief answers. But for those that do need to leave, we understand. Thank you.
Thank you so much. I'll try to respond to, I think, two questions. The first one, I think my lady from SADC, she has almost answered it. It was from our researcher here, saying, how do we penetrate our communities? I think she has said it all. I think the use of our local agencies, it is very important, because the strategy which you use in Indonesia will not be the same which will be applicable to Malawi. But what is applicable to Malawi, you can use the same in Zambia, in Tanzania, in Zimbabwe, because culturally we are almost the same, faith, whatever, we're almost the same, even politically, so we understand each other. So I think the use of local HSS, it is very, very important for penetration and for also domesticating some of the interventions which we want to use in order to make sure that we provide services of SRHR. The second one was the concern about the huge numbers, the increase in the cesarean section. It is also a very huge concern to us as a country, Malawi. I have my director of chief of health services. We have been talking about this, and as a country, we have set ourselves targets. We call them 90, 90, 80, 80 targets for maternal and newborn. We are saying 90% of our women should have at least 4+ antenatal care visits, because one of the issues is the issues we have. We all know the issues. You have to walk 10 kilometers. Who has the time to walk 10 kilometers to go for antenatal? You can't do that. So we have issues with infrastructure, the issues, those are the issues which are also contributing to the increased number. And of course, the issues of healthcare workers, issues of midwives, issues of nurses. We have a high vacancy rate, almost 50%, where you need to have 10 midwives, you only have maybe 5. So those are the real issues as well on the ground, which I think as governments, we need to work on. So we are saying we also need at least 90% institutional delivery and births. So we don't want our women giving birth in the roads or at home, wherever. No. So these are the targets which we have set for ourselves, just to make sure that, we need to do something. It is not right that in this 21st century, we still have high numbers of women and, cesarean section. The women, they go home. Our women, when they go home, they don't have the luxury of having 3 days or 4 days bed rest. No. Once you go out of the hospital, you come home straight away. You have to cook, you have to take care of the other children which are there. You just have to look after everybody else. So at least let's make sure that they give birth normally and then they go back to their lives. Thank you so much.
Thank you, Minister. I'm going to pass it to Minister if you want to comment too.
Yeah, some reflections. Regarding your comment, Argentina was one of the first countries that considered pregnant women as a risk group, and we protected them through the vaccination. And at the beginning of the pandemic, COVID-19 pandemic, it was very, very early when Argentina also decided to keep the centers regarding gender violence open and to consider this an essential service, and they were allowed, even in the worst part of the lockdown, to go out and to contact regarding gender violence. I didn't talk about that, but it's an emergency. I agree on that, and it has been worse after the pandemic due to the mental health situation, due to the problematic substance use also after the pandemic. All of that has been worse, and we are not being able to transmit or to make it get the attention for the decision makers or to the media also. In media, the problem is not treated well. Sometimes it makes, at least in Argentina, more violence because it's like an example, and then another situation similar happened. But I think that this is a very complex challenge. We are talking about women's health, and this is not a disease, and this goes extremely beyond health, and we need a very transversal and political commitment, but also invest and also first to understand the critical situation. I think we are not there yet, and this is the thing that worry most myself, and I think all of us. But maybe we can think about a strategy, a stronger strategy, a more aggressive strategy, in order to put it in the highest level, in the red light, because it's an emergency. Absolutely.
I think already Excellencies talk about the localization of the solution, and what I want perhaps to highlight is the fact really we are working to improve the quality and the rights of women and access to sexual and reproductive health. And what I learned from this is we need to do something for country in development, but also we need to keep our eye open for the country who we think they need to be the first to bring the others in this position. This is something just, I think more and more we have less and less women standing to bring the right of women, and I think we need to get more and more women in this position to do this work. Thank you.
To quickly respond to that question on increasing number of cesarean cases, at least in India, if you look at the trend, it aligns with the policies and programs that were launched to promote institutional deliveries. And then along these programs, health insurance policies started coming up. And as a result, more and more cesarean sections were being promoted. It is actually not only cesarean sections, but a lot of additional procedures. For example, hysterectomies. The first RSBY, Rashtriya Swasthya Bima Yojana, the first health insurance program that came for the below poverty line population in India, saw an exponential increase in hysterectomies of women under the age of 40, where actually they were not required. So if you see, actually these processes and procedures are systematically induced into the system and normalized for the population without making them realize that that is even an option. And this points to women's agency, because in many cases in rural hospitals, if you go, I mean, woman is on the bed, a pregnant woman is on the bed, and if it has to be a decision between a cesarean section and a normal section, normal delivery, the decision is not actually discussed with the woman, but husband, mother-in-law, and other members of the family. So that reflects a lot of where we are, like in terms of women's agency. And that is why we need to have more women and people from all diverse backgrounds on the leadership positions, so that they can really truly reflect the needs of the population.
So on that note, I want to again thank all of you for coming and joining in today's conversation. Thank our sponsors for this event. Thank the ministers for taking time to join us, and really the deep thought from civil society. It is clear from the discussions today that we will not achieve universal health coverage by the target end date of 2030 without including sexual reproductive health and rights, and really centering it on human health and health systems. I also want to note that we must not forget to recognize the health workers who are essential, and we've heard that message strongly today, to delivering all health services, including those discussed today. After more than 3 years of the pandemic, significant numbers of health workers, especially women who are 70% of the health workers globally, are burnt out and are resigning at high numbers. We've heard that clearly today as well. In leaving this profession, I want to leave you with 5 closing points, which are: we must ensure gender equality in health system leadership and decision-making at all levels. We heard that today, that having women and people from all diversity must be part of decision-making. 2, it is critical that we retain and recruit women health workers by ending gender inequities in the health workforce. 3, to achieve universal health coverage, we must design, properly resource, and deliver health systems based on gender-responsive policies and health services. 4, universal access to sexual and reproductive health services must be designed, resourced as essential services, and mainstreamed in national health policy frameworks with local solutions. 5, to know how far we've come, we must monitor and evaluate progress toward universal health coverage and data and analysis disaggregated by sex, gender identity, and other relevant stratifiers. And last but not least, we call on our member states to fully deliver on all the commitments to gender equality and the rights of women and girls at the high-level political declaration made on the UN General Assembly in 2019, and build on all these at the second high-level meeting in September with strong commitments on implementation. Again, thank you all. Have a lovely rest of your evening. Thank you.